Hi, good evening, everybody. We've already got 20 participants, which seems like a good number, and more people will join as we go along. We're very excited. We're now in week 3 of our rural onboarding course program, and this is our, I have to keep track, our 5th webinar, 6th webinar. We're on Wednesday night, 6th webinar, and we're still in the theme of emergencies, but also starting to look at more of our medical emergencies and our non-communicable diseases this week. And I'm very pleased to welcome this evening to our forum, Professor Andy Parrish. He's also Eastern Cape. We've got a strong Eastern Cape contingency on this program. Prof Parrish is currently HOD at CMH Hospital, and he has various roles that he fills. So he's Associate Professor for Internal Medicine at Walter Sisulu University. Is also an Honorary Associate Professor for Internal Medicine and Clinical Pharmacology at UCT. Important work is his work as co-chair of the National Essential Medicines List Committee. So every time you use the EML, you know who to be grateful to. Also the chair of the NEMLC Covid Committee. He's got a strong interest in EBM and knowledge translation. And his particular love, which I've always remembered him for, is training up young doctors in the intricacies of internal medicine. And he's been part of an amazing project. I'm hoping he's going to tell you more, called the BAMSI project, which is supporting the Buffalo City and Amatola district for mentoring and support and doing outreach and support of rural doctors in those rural areas. So really knows the kinds of challenges you guys might see. So welcome, Prof, talking tonight to us about internal medicine emergencies. It's really lovely to have you here.
Great, thanks for having me, and any new venue is always a delight, and so I'm pleased that we can get going here. I'm going to just switch off my video just now because my connection is not perfect, but I just need to check that my screen is sharing. Let me just put it on full blast. There we go. Is it coming through, Madeleine? Can you see my screen? Okay, so let's get going then. I assume if it's not working, somebody will yell at me. So essentially, I've got a string of slides which are going to be about the emergencies that you may or may not encounter in wherever you're working, but the likelihood is you'll meet all of these, so I don't feel shy about talking about any of them. The issue is that you can either talk in great detail about one or two, which would be fun, but not necessarily particularly rewarding for you guys. So what I've got is a concept here, which is what we've been using in the department now for some years, which is a 5 in 5, 5 minutes and 5 slides. And if you can't say it in 5 slides, it probably isn't worth saying. The idea then is I've bunged a whole lot of those things together, and it really does make things more concise. So the idea really is that we'll cover some of those topics. There's obviously lots more we could cover, but these are crunching through quite a lot of the stuff you see. And then I hope there'll be lots of times for questions and things. And obviously, if you want to chirp during a particular topic, then obviously do so. I don't mind being stopped at any stage. But it will be a bit of a roller coaster, so hang on to your hats and let's see where we go. All right, so the issue with these presentations is that sure that you may want to go back on some of them, but this one is relatively straightforward. So the first thing I want to do is, as Madeleine said, is just talk very briefly about our website. So it's in the top right-hand corner there. It's Medival, M-E-D-E-V-A, or without an I, it's not medieval, at COSAR. And the /WP will take you to the first page, which is this bit at the top here, where there's 3 places you can go. The learning opportunities is the key one. That's where BAMSI's, most of its work has been up to date. There are 29 lectures that you can join in and review there at your pleasure. And we're hoping to add another 20 odd this year, so we'll have 50 or so by the end of the year. On the left here is what's left of my the handbook of internal medicine for the East London, which is essentially was a bit of a tome. It was getting too long and too detailed. And so what we've done is split it up into little bits now. We lost out on funding from the Department of Health anyway, so it wasn't as if it was going anywhere in a printed form, but it's all here if you want it. And we can talk about that too if you want, but it's still a work in evolution. If you do go there, you don't have to register or log in or do anything. You can just bounce in there and bounce out again at your heart's content. But if you do go there, there is a section under every topic for comments. And if you want to put in comments and chirps and stuff that's wrong or stuff that you think should be there, please feel free to do so. It'll arrive as an email for me, so you can either do it anonymously, or if you want to enter a conversation, feel free to do so. And then the final section here, which I'm not going to talk about at all, is our audit arm, which we are hoping to strengthen this year in terms of quality improvement and clinical improvement, but that's a separate thing. I'm not going to go there today. So this is the first patient, and I saw her yesterday, and the moral of the story is we need you to think. Okay, and the issue here is the middle of that thing. So this is a lady who comes in with a swollen tummy, and somehow, because she had some PV bleeding, she ended up with a Guyanese and ended up having a whole lot of tests done, including tumor markers. There was a string of tumor markers, and one of them, unfortunately, was positive. It was quite high, actually. And so she sort of was labeled as needing all sorts of gynecological assessment. Ultrasound showed nothing, but in the notes, you can fish out there S1, S2, normal, no murmur. And that has to have been done by a doctor with their brain switched off, as in like there was nothing glowing at all there. Because when you examine her, she's got anasarca, her JVP's up to the angle of jaw, apex is displaced. She's got an S3 and an S4 making a beautiful summation gallop and a 3/6 mitral regurgitant murmur. It's not quite loud enough to feel, but it's certainly audible to young ears like you guys have got. And a quick echo showed her ejection fraction at 40%. So she's got a dilated cardiomyopathy. She may well be nephrotic as well, but that's a separate issue. The point being that you need to think. I mean, this lady was in heart failure. There was no doubt about it. Tumor markers go up in people with heart failure. You may not know that, but trying to squeeze this lady into a cancer label when all you had to do is look at her to see that she's got something you can fix with some furosemide is really what I'm gunning at with this first slide. Okay, so try and think about it, try and put it in context. What's the gist of what's wrong with the patient, rather than just reacting to the numbers? And here's another one, and this is numbers gone terribly wrong. And this was a cat chasing its tail from a district hospital close to us. And this poor patient had a syphilis serology, which was done. She had some neurology symptoms, and I won't go into this in detail, but essentially presented about a year ago with a positive serum serology, negative CSF serology, but was treated as neurosyphilis and meandered through the system. And she's got an enormous craniopharyngioma and or pituitary tumor, I think probably the former. This whole thing in the middle of her, front of her head there, and papilledema and all the good things. And again, if you see a number like a positive VDRL with a titer of 1 in 125, that doesn't mean somebody has only got syphilis. There could be something else going along. So don't chase your tail, chase the patient in general and try and work out what's going on. So that's just a preamble. Keep your brain switched on and let's bounce through the next section. I'll start off with aggressive disruptive behavior because that's always something that gets your attention in casualty. So the thing is think. Have your backup team ready, know how your backup team is sort of coordinated and how to get them going. Stay calm, obviously don't be confrontational. Don't turn your back on aggressive people, and go for respectful manual restraint. And remember the Mental Health Care Act and the need for regular observations if you've tied somebody down. So the team approach is one for each corner and one for the head and one to give the restraints or apply the restraints or give the injection. Remember, when you're applying restraints, don't apply them to trolley sides. Those things are quite frail. Tie them to the trolley itself, okay, not to the rails, because we have had occasions where patients have marched around casualty holding the rails in their hands, which gives them a lovely extra weapon. So beware of that. And talking of extra weapons, don't go there with a patella hammer or another hard thing like an ophthalmoscope that can be used for abuse in your pockets. And beware of biters too. So ensure that you keep your hands and fingers away from the mouths of people who are psychotic. And then the last thing is, once they've been restrained, they still need monitoring. You don't just tie them up and march away. You need to keep an eye on them. All right, so how do you do it? Now, there's a whole choice, and I'm going to spend a little bit of time on these medications, but tranquilization sometimes is feasible orally. You can sometimes actually get somebody, and they're sometimes very keen to take a pill. So if they're keen to take a pill, just give them a pill. It'll work in about 15 minutes longer than the parenteral dose. So, don't feel shy about giving it. By the time you've sorted out your injections and your restraints and all that, the patient might already be starting to feel sleepy if you do it. But obviously, if they refuse it. And in that case, you have to go on to IM. And I'll come through the various drugs here. Periodol and promethazine. Unfortunately, haloperidol is not available at the moment for various reasons in the parenteral form, but that combination is one of the best tested in the sense that we have randomized controlled data on it. The rest of the stuff is horrific in terms of evidence for what works. Clothiapine has been around in South Africa for decades. It does work, but it causes orthostatic hypotension. So when your confused patient yells the house off when he's lying flat and immediately goes quiet when he sits up and lies down again, just check his blood pressure. He may be profoundly hypotensive. And then obviously zutopenthixol is another option. The issue around these things is that the benzo story is back to front in most people's head. What you're wanting to do is to get somebody to fall asleep and then stay in a drowsy state for some time, particularly in casualty situations. You don't want them sort of fixed for an hour or 2 hours and then bouncing around again, because it doubles or trebles your workload. So the ones you thought you'd fix come back to haunt you like Lazarus on a bad day. And it can get quite messy if they all get bouncy at the same time. So the idea is get people to be sedated and stay sedated, or tranquilized, depending on what you're aiming for. And the problem here is that people get mixed up between a serum half-life and a biological half-life in your brain. So the benzos have varying degrees of steroid solubility, of lipid solubility. And for that reason, their action in the brain is very, very different to their serum half-life. So diazepam, you all know, has a long serum half-life, but that's not the point. It doesn't work very long in your brain because of its lipid solubility versus the others. So lorazepam works longer in your brain than diazepam, and it's important to know that. The other way of looking at it is here. This is a rather turgid paper. If you want to read it, you can. It was from 1999, but it basically goes through all this in detail. So diazepam in your head, to less than 2 hours, midazolam 3 to 4 hours longer than diazepam. Okay, for those of you who think midazolam is the short-acting, quick sedating, and quick off, it actually is better to give diazepam if you want somebody to wake up quickly. And then clonazepam and lorazepam are much longer. You should all be very skeptical about this graph. I pulled it off one website just to show you a bit of EBM. We've got to get a little bit in. Be wary of any graph where you see a line with effect, this y-axis with no markings on the side. It's like a graph in a newspaper. Ignore it completely. But the message from this paper is that diazepam is probably the shortest acting in terms of its ability to keep somebody sedated or fit free. And we'll come back to that with epilepsy. All right, so I think that's the main thing. I mean, we can go through each of these ones in detail, but quetiapine, or etamine, as you may know it as, again, it's in the Cochrane database. What they say is the evidence is very weak, but it probably does something. It's no better or worse than alternatives, essentially, and that's our alternative to haloperidol. The dose is anything from 20 to 40 milligrams 8 hourly. You can go up to higher in long-term use, but in your acute sedation, don't use industrial doses because of the blood pressure. Zeuclopin Thixol, very similar. Again, Cochrane says no better than no worse, and 25 to 50 milligrams, probably as effective as higher doses. All right, so that's where I was going to stop with that. I just wanted to open the batting with something about sedation. And if you've got questions, we'll do that in the end, unless somebody's got a burning one now, in which case just yell it out. I want to then move on to the next subject. So we're hopping all over the show here. The next one is hyperglycemia, and I'm going to give you two quick scenarios. Firstly, on your morning round, a 19-year-old man who's admitted as acute pneumonia, and he's on his ceftriaxone, of course, and his background takes biphasic insulin, but he went to a party at his friend's house and, of course, forgot his insulin. And he's afebrile, his respiratory rate is 28 per minute, and he's sighing away with a glucose of 31 and 3+ ketones. So that's him on the one side. And, of course, you obviously all recognize that as an acute DKA and know how to manage it. We'll come to that now. On the right is a completely different story. It's an elderly person with hypotension, a tachycardia, fever, and a septic foot. She's also got acidotic breathing. She's also got raised glucose. She's also got ketones because she's starved and not eating, more than necessarily because she's got no ability to get glucose. But her problem is hyperglycemia, causing an osmotic effect, and his problem is lack of insulin, causing a intracellular glucose deficiency disease. Very, very different pathophysiology and different management to some extent. So reminder again, so here it is, the patient on the left, I've got my things mixed up in terms of the colors, but the young guy has got a order that says, can I have ketones? I'm getting any glucose into my cells. And the bottom line of that is an acidosis. So it's starvation in the midst of plenty. DKA is a glucose deficiency disease, not a glucose excess disease. You want glucose in cells. You don't want to worry so much about what the serum glucose is doing. You want the ketones to go away and the acidosis to go away because the cells are no longer starved. Think of it like that. It's much easier to manage. The hyperosmolar lady is completely different. She's lost water in large amounts with this osmotic diuresis and sodium, and in trouble and needs water, lots and lots of water to fix her up. But she's also at more risk in terms of that because she's more likely to have heart failure as well if she's elderly. So we need to think about the thing. The DKA is high ketones, metabolic acidosis. They're breathing fast, and the cause is usually insulin deficiency. Can obviously be infection quite commonly. The potassium in DKA is variable, but usually high or high normal when they come to see you. And they may be, depending on how high the glucose is and how long the DKA has been going on, they may also be dry, but often aren't. I mean, that guy with a pneumonia could quite conceivably have a urea of 3 and still have severe DKA. And he doesn't need lots of water, he needs insulin. Okay, so now everybody asks, well, what about the blood gas? You can't manage DKA without a blood gas. Now, in the Eastern Cape, at least, this is an interesting knock-on effect because the company that sells the cartridges for the blood gas machines is not particularly well paid at the moment and is not keen on providing any cartridges until the new financial year. And the machines are now all over the province, which actually means that referral hospitals probably have no more access to blood gas than some of the smaller district hospitals, which have a machine and a cartridge that's not overused. So the first principle is venous is fine. You don't need an arterial blood gas to manage a DKA. All you're interested in is the pH and the bicarb or base excess. And if they're getting better, if the respiratory rate is coming down, they're not breathing as deeply, the glucose is coming down, you don't need to do dozens and dozens of pHs on those patients. As long as you're heading in the right direction, it's fine. It may be useful to keep an eye on the potassium at night with a blood gas machine if you do have one. And one last point is be careful of homemade anticoagulation methods. The unfractionated heparin that's around is either 1,000 or 5,000 international units. But if you leave even a quarter of a mil of that in a syringe, a small 2 ml syringe, you can quite easily have a horrendously acidotic result because heparin is a very acidic molecule. You can use lithium heparin tubes, those green ones, but don't believe the CO2 in those. All right, that's just blood gases, water. So the issue is which fluid and how fast. The short answer is salines. American companies trying to sell fluids other than saline because they can make money on proprietary solutions. Normal saline in all the indications at the moment hasn't been shown to be worse than anything else. So it's cool to go on with, to start with saline. Down the line, you might run into problems of hyponatremia if you are correcting a severely dehydrated patient. But and also if you just pour in gallons of fluid to people who don't actually need it. But generally speaking, that'll be a problem for day 2 or 3, not in casualty. The dose of water is unknown. Nobody really knows where these regimens came from that said you must pour in gallons. Nobody's shown that less aggressive ones are worse, but the trials are too tiny to say anything. The only thing I'll say is don't drown old people. If you've got somebody with reduced cardiac reserve and you use the same fluid replacement regimen as you would use in a 20-year-old athlete, you will clearly run into problems. So be careful of that side of things. The insulin, again, very weak evidence of what works best. 5 to 6 units an hour is fine. How you get it in is up to you and what's available in your site. If you've got a pump, you can put it in a pump or a syringe driver. If you haven't got either, you can give it IM, 5 or 10 units an hour. If you can't give it like that, there's some data that's just come out in the last year or two looking at pediatric DKA, showing that if you're not actually shocked, subcutaneous insulin every 4 hours probably is okay too, but we can go into that evidence if you want to. It's not very strong either. None of this evidence is strong. Potassium, if you're going to give potassium and you know potassium is already low, then get cracking. If you don't know it and the patient is passing urine, it's probably cool to get going and start with it, even in the absence of knowing the potassium. It's very unlikely you're going to make somebody lethally hyperkalemic if you're giving them insulin and they've got their own glucose. So once the insulin is around, the potassium almost invariably drops fast, and the cause of mortality is hypokalemia, not hyperkalemia. So, if you're not sure what to do, rather give potassium than don't give it. And so the aphorism that, if you can't measure the potassium, give a couple of bags, and then after that, they'll be passing you, then it's probably fine to add potassium. Some of the district hospitals have a rule that you can't mix potassium in the wards. That's fine. You can have it pre-mixed in the pharmacy, but just make sure you've got enough bags to last the night. This is what we don't. There's been several deaths in the country from KCL. And, KCL has been used in the past in the States as a way of sorting out their death row inhabitants. So please don't write it up like this. This is a genuine script, KCL 1 amp IV stat. That is lethal and should never have been written by a person with a medical degree. But be that as it may, it was. and fortunately the nurses were wise enough not to give it. The way to do it is a little bit more conservative like this, and mix 40 millimoles, that's 2 amps, each containing 20 millimoles of potassium, in a liter of saline. Mix it thoroughly. You can squirt it in the bottom and it'll be quite concentrated there too, and infuse over 6 hours and then repeat it 6 hourly. Sometimes the nurses are scared of doing this, and you should label it and when it started, should it be running for. If it gets behind, don't just, but just be careful. Don't just pour it in IV. All right, have you really looked for sepsis? And those are the places you looked. Did a chest x-ray and I looked at the tummy, wasn't sore, and I put a dipsticks in. Issue rectal abscesses, septic palmar spaces, gangrene of a toe under bandage that nobody bothered to take off. The common ones, and they all are DKAs don't, or hyperosmolar states don't get better. Surgical style sepsis is a surgical problem. It can't be solved with insulin and water. It needs source control, basically. And until you've got that, you're not going to win. All right, I'm going to move on now. I know I'm bouncing along, but that's the idea here. This is asthma now. Remember that we are talking about an expiratory wheeze and a reduced peak flow, which means you've got a peak flow meter. Find out where the one is in your casualty. If there doesn't seem to be one, find out where it's been locked away and unlock it. Make sure that you blow the dust off it and then get it used. If it isn't there at all, they cost 100 Rand at Dischem or wherever. Go and get one and make sure that the hospital has one, or make sure your hospital manager orders some so they're immediately available. You wouldn't dream of managing hypertension without a blood pressure monitor. Here, we think we can manage asthma without a peak flow meter. You can't. I can't tell what somebody's peak flow is by looking at them and listening to their chest. Neither can you. That's what the meter's for. We've had some incredible surprises. The anecdote here is the one I had some years ago, asthmatic I knew well. The registrar said he needed help intubating because he had a short neck. Called me out of a meeting, went to look at the guy, and I said, let's just check his peak flow first. He was wheezy, distressed, looking in imminent need for intubation with a peak flow of 550, which is his normal one. He was just terrified and just needed talking to and calming down, not tubing. But you couldn't tell that by looking at the guy. You needed to know his peak flow. Think of heart failure, think of stridor. In other words, the wheeze is inspiratory rather than expiratory. That's not going to get better with bronchodilators. And formally record all of those things, the pulse rate, the respiratory rates, the blood pressure, the pulsus paradoxus. We can come back to that in question time if you want, and the peak flow. And asthma is reversible. It's a condition that gets better. The patient should have a normal lifespan, should have normal effort tolerance between attacks. And it's your job after the acute to make sure that the patient knows that and knows what their peak flow is and demands from the health system that it be kept well above 80% of expected for his age or height. COPD is the other thing. I mean, everybody with COPD gets labeled as asthma because they wheeze. They've got a very limited effort tolerance, even when they're feeling well. The peak flows are often extremely low, although they're quite comfortable wandering around the ward. It's a completely different condition and needs to be seen as such. It's not fully reversible, though. But please don't label all your COPDs as asthma. They aren't. They can't get better back to baseline because they've got damaged lungs either from smoking or TB or both. One slide on NEBs. You don't write give NEBs. You must prescribe NEBs. And the point about them, and particularly with a very ill patient, is that they need to be getting them almost continuously. 5 ml in saline and nebulize at 6 liters per minute and over 20 minutes. And then you can repeat it continuously. The point about that recipe is it stops you poisoning the patient, and it stops you giving intermittent nebs. Intermittent nebs make patients terribly nervous. Where's my neb? Where's my neb? They want it back. And if you're not diluting it like that, you can give them too rapidly, and the patient can then get a toxic dose of salbutamol, which gives them a SVT of 180 a minute and a SVT in the doctor, and all hell breaks loose. So just try and keep the neb rate constant, which is that 15 milligrams an hour is fine. Anything above that tends to cause a nasty effect. So that's that. Let's move on to some pitfalls. I've got you a picture there. Hypertension, you need a blood pressure cuff. Asthma, you need a peak flow meter. That's funny thing at the bottom there. Yes, they are dirt cheap. It's a spring and a pipe. Anybody can make one in these day and age, so they're readily available and not expensive. The X-ray on the right is, if you look, there's 3 bumps on the left heart border. There's aortic arch right at the top. Then the pulmonary conus just below that, and then at the bottom of that is this 3rd bump, which is the left atrial appendage. So this patient hasn't got asthma, they've got mitral stenosis, and you can tell just by a quick glance at that X-ray. So when you see that X-ray, you want to give the patient furosemide, not beta-2 stimulant, because a beta-2 stimulant will make their heart beat faster, and that's not good for somebody with mitral stenosis. Be careful of pneumothoraces, particularly the rather sad occurrence of a bilateral pneumothorax, which sometimes happens, and it looks equally black on both sides, but just think about that. And avoid homeopathic theophylline IV. It's really not a great drug. If you don't ever prescribe theophylline in your whole life, that will be a good space to be in. IM adrenaline is for ambulance drivers who haven't got facility to nebulize. It may work as well as nebulized salbutamol, but if you can nebulize with salbutamol, there's no evidence there's any additive effect from using the 2 together. You don't need to give antibiotics. A bit of yellow sputum is quite common in somebody with an acute asthma attack, and multiple doses of IV corticosteroids just make the nurses busy. Oral is fine. All these statements are from Cochrane systematic reviews, almost a decade or more older now. We know this stuff relatively well. This isn't rocket science. So you can go with a single dose of IV corticosteroid if you want to, but after that, prednisone is fine. Furosemide doesn't work for asthma. It works for heart failure, sure, but you don't have to give it to people. And again, think of the consequences. Giving furosemide to somebody who's got an undifferentiated wheeze might seem like a good idea, but if they actually have asthma and are critically hypoxemic and in trouble, sending them off to the toilet when they're in trouble is not a great move. All right, and we're getting there. Heart failure. So here we've got cardiomyopathies, core pulmonale, and pericardial disease, and obviously renal failure and nephrotic syndrome. The cardiomyopathies are relatively straightforward if you bother to examine. It's quite easy. It's great fun. It's exactly why we learnt medicine and do medicine. Swollen legs plus the raised JVP plus the displaced apex. You're in business. If you feel like hearing a gallop, that's cool. If you can't hear it, that's also cool. But once you've got a displaced apex, you know where you are. Core pulmonale, often cyanosed. If you put your hand on the sternum and your palm gets rejected by a very affronted right ventricle, then you know the patient's got pulmonary hypertension, and a purple patient with RV lift has not got a cardiomyopathy, they've got core pulmonale, and they're not going to respond to enalapril and spironolactone and all that stuff. It's not for them. They just need some furosemide. And beware of pericardial disease. You can't feel the apex. The heart just is sulking somewhere else. It doesn't seem to be doing anything much, but there's a raised JVP and swollen legs. When you do the chest X-ray, the heart looks either really small if it's a constriction, or it looks really big, and then you say, but I should have been able to feel that apex, why can't I? And the answer is because there's a bag of fluid around it, and you pop your ultrasound probe. Even an obstetric probe can pick up a pericardial effusion. So you shouldn't really have an excuse not to be able to diagnose it. Okay, Now, comes off our website. I've just put this up really to illustrate something that I think is best shown pictorially. So the size of the circle is an idea of how much persuasion you get, how much it changes your probability after you found that thing that the patient has heart failure. If you've got an elevated JVP or a displaced apex, like I've just said, they are cool. They are very specific signs of heart failure, and they move your probability the patient has a cardiomyopathy into a very likely space. Remember, the sensitivity of all of those tests, though, is less than 50%. So you may not pick up any of those things and still have a patient who's got heart failure. The S3 gallop is not really a particularly good sign in terms of moving you into a definite cardiomyopathy. Lots of other things cause basal crackles, so that's sort of a bit in between. All right, so go for the gold. If there was more time, I'd give you an opportunity to tell me what this is, but I'll just show it to you. So there you've got a rhythm strip at the bottom. And if you look at the curious complexes, there's a big one and a little one, a big one and a little one. And that's called an electrical alternans. And when you see that, you can say the heart is moving around in a bag of water, so that the electrical axis changes from beat to beat. And if you look on your echo, you'll see that quite easily. And that's fairly pathognomonic of a pericardial effusion. You can sometimes see it in COPD, but very unlikely. There's usually a respiratory change there. There's a pericardial effusion. I've deliberately put in a bad picture because it's good enough. You can see that black line at the top, then there's the right ventricle below that, then the left ventricle below that. If you see that big black blob there, you know you've got a pericardial effusion. This is not a pericardial effusion because if you look, even though there is a big cardiac contour, the lungs are congested. And if you look at the right base, you've got some little white stripes coming in from the side. I'm going to blow them up for you. Same patient, those little white stripes are called curly B lines. And when you see curly B lines, it probably means that the patient's got pulmonary edema, and a little bit of furosemide is great for that. All right, management, furosemide, ACE inhibitor, spironolactone. Isosorbide is in all the emergency texts. It's worth a try if the blood pressure isn't too low. Just be careful if somebody's got a low blood pressure. They don't sometimes do that well with it. Don't forget some thiamine if there's alcohol abuse. And then furosemide, just the corpulmonale, just the furosemide. Pericardial disease, obviously, whether to aspirate, we can talk about that. The pitfalls are treating corpulmonale as a cardiomyopathy, giving spironolactone in renal impairment. If the creatinine's high, you get hyperkalemia if you give spironolactone, and same applies to digoxin. You don't want to give that to people with kidney disease. The other problem is not giving the ACE inhibitors to somebody who's got a cardiomyopathy. That's mean because they will benefit from it. It'll improve mortality outcomes. And don't forget thyrotoxicosis, mitral stenosis, anemia, and pregnancy. We once had one patient who had all 5 of those things when she presented. It was quite interesting. The intern was a bit round-eyed. I said, look for all of these things. And she came back finding all 5 of them. I've only got one slide on this. Inferior MI, look in the bottom left corner, 2, 3, and AVF. And anterior MI, look in the middle. Anterolateral, look on the side. So it's V1, 2, and 3 for anterior, and V1 to 6 for an extensive anterior ST elevation. And the anterior one, you can see the Q waves are already formed there. So that's an older one. And give the aspirin. Thrombolysis is feasible in a lot of spaces if you've got the drug available. Any hospital can do it. Don't rush in with beta blockers and enalapril in patients with acute infarcts. The evidence that they make a difference in the acute phase is less strong, and sometimes you turn somebody who's relatively stable into a hypotensive bradycardic mess, which is problematic in terms of transporting patients. So just be careful, particularly with the beta blockers in acute MIs. Control the pain with whatever you need to control the pain. but don't give oxygen to patients who aren't hypoxic. There's a little bit of data suggesting it worsens outcomes. This is just easy stuff. Enoxaparin, once you've got a swollen leg and have had TB, it's DVT, and it's not much else. It's likely to be vitamin C deficiency with scurvy, and a bleed into the leg is possible. Look at the gums. If the gums are bleeding and somebody's really malnourished and has TB, think about scurvy. It's rare, but we see it every now and again, and obviously it doesn't respond terribly well to anticoagulation. Right, I'm going to end off then with a few slides just on stroke. Basically, there's such a common problem, and the first point is speak to both the family and the patients. A lot of stroke patients, there's very little we can do for in terms of rushing them off to a bigger center, but a lot you can do for them in terms of counseling. So give an aspirin, test the swallowing and see if they can swallow, and if you're not sure, use a nasogastric tube. Beware of the usual culprits: incontinence, they might need a catheter, bed sores, aspiration if the nurses find out they can't swallow with the first bowl of porridge, and beware these patients are often dehydrated. It's not uncommon to find these stroke patients admitted and getting no fluid for the first 12 to 24 hours. Imagine if you invited somebody to your house and then didn't give them anything to drink for the first day. You wouldn't be very popular. And then the last thing around here is don't overtreat that initial blood pressure. It settles, and I'm going to show you a slide on that just to demonstrate it just now. If it's a young patient with a stroke, be really careful that you've looked for a cause. Check the blood pressure yourself, feel the pulses all over the show. Think about, Tachycardia does happen. Think about the heart. Are there murmurs? Don't write S1, S2, no murmurs. Switch on brain, get flowing with that stethoscope and really get into the jive of listening for the murmurs and the rhythms that they've got there, and do some basic bloods, HIV, syphilis, ANA in those patients. Here's the slide. This is from a trial called CATUS, which was done in 2014. That's 7 years ago. They published it, okay, which shows this thing. And it was 4,000 patients. It's big enough to believe, and it's definitive. And yet people still go ahead and do it. What they did is they randomized people to either getting none of their routine blood pressure pills when they were admitted with a stroke, or to carrying on with targeted blood pressure treatment to bring the blood pressure down a certain amount. And all of them were, or the majority of them were hypertensive on admission. And as you can see, both groups, the blood pressure dropped to a safe level, and there was no difference in any outcome that was patient relevant. So you don't need to rush in with antihypertensives on stroke patients. It's better to not give the pills that they weren't taking at home anyway when they get admitted, because they get hypotensive and the stroke area increases, the watershed area turns into a further stroke, and they get dehydrated because you put them on diuretics as well. So try and be careful with blood pressure pills when patients are admitted. Thrombolysis, I've just put this up to remind you, no difference in mortality, 4% absolute reduction in death or dependency is the bottom line of it, and only 5% of patients coming to emergency units are candidates, okay? So of those 5%, there's a 4% of that group, so a tiny number of people who benefit from thrombolysis in relatively good areas of supply. I'm not going to go through this in detail, but again, most of the trials on thrombolysis didn't actually show it worked particularly well. 2 of them did, and it's on the basis of those that the whole industry is built up. I'm not saying you mustn't do it. I'm not saying it isn't worth referring a patient who comes in early, but the number of patients in the global pool of stroke patients who benefited from the thrombolysis is tiny. Right. Last one is epilepsy. And is it status? They defaulted medicine 2 days ago. They fitted at home and again in casualty. They're awake but drowsy. Think about it for a minute. Would you give them a load of phenetone or a load of whatever, or are there alternatives? So quasi-status is really not quite that. It's a flurry of fits. It's not the same as a patient who's not returning to consciousness, having prolonged fits that go on and on and on, with no recovery in between, and they are very different in terms of brain prognosis. So if the patient's awake in between, they've had a flurry of seizures, they probably may or may not have had an alcohol binge, but they can generally be managed more or less aggressively than a true status. And obviously check the glucose, and you can give them one of those 2 long-acting benzos and restart the meds the patient's usually taking, and Bob's your uncle. It usually settles down. So this is the difference between an IV load of phenytoin and an oral load. On the right, that would cost a few cents, literally. I think they're 5 or 6 cents per tablet of phenytoin. And obviously the little vials are about $30 each. So if you keep on loading IV phenytoin, you'll soon run out of IV phenytoin and then have to use IV valproate, which is even more expensive. Please make sure that you give enough glucose if patients are hyperglycemic. They may need more than 1 dose. Remember the loading dose of phenytoin, if you're going to use that, and it's the same for valproate if you're going to use that, is 20 milligrams per kilogram. For those of you who are calculator impaired, although you've all got cell phones these days, double the weight and add a naught. So if the patient weighs 60 kilograms, that's 120, and then you add a naught, and that's 1,200 milligrams, and it's a 250 milligram amp, so you give 5 of them. But don't give 750 as a routine to all people in status. It doesn't work. It's not enough, okay? And it's a cause for prolonged status and brain damage. Please don't write up Valium PRN. It never gets given. And please don't give IM diazepam either. It'll be absorbed the next day and won't have any effect then, but will put your patient to sleep the following day. Here's a one to just cheer you up at the end. Undifferentiated abdominal pain we saw quite recently, epigastric tenderness. Think, please. She was treated twice for her peptic ulcer disease and it didn't get better. And this is her chest x-ray. It's very easy. You can see she's got a big thing somewhere at the top there, just above the heart. And that's a crying back, and if you look at her back, this is what she had. Okay, so she was treated for literally months for her abdominal pain, which was all referred pain because nobody bothered to put their hand on her back, even to examine her back, and it would have been an instant thing. She got away with it. She didn't end up paralyzed for life, but it would have been so easy for this to have progressed just a little bit faster and for her to have been a permanent paraplegic, because the doctors who were prepared to prescribe omeprazole or lansoprazole weren't prepared to touch her. It's a medical emergency, an acute paraplegia. It needs to be looked at as soon as possible, and really think about TB and other causes. It's usually TB or malignancy. In HIV patients is obviously a wider spectrum. Right, so I'm going to end there so there's some time for chatting if people want to. I've literally done a roller coaster, so I hope you're still with me. But the themes of the thing is think, and think some more. When you do examine patients, really try and do so with attention. It's fascinating how much more information you get by doing that. It makes the whole subject much more rewarding. Don't ever in your life write down S1, S2, no murmurs again, and manage the patient, not the numbers, and think about whether your management plan is actually sensible. So that basically is my story. I'll stop now and leave you up to question time, if I can work out how to do this.
Thank you.
Screen share.
Yeah, no,
There
that's
we go.
perfect. Thank you very,
Right.
very much, Andy. There's some comments on the chat that I think were sort of added throughout the presentation. So you're welcome to look at the chat and see if there's any of those you specifically want to comment on or pick up on. Otherwise, people can put up their hands, or they can also just unmute themselves and shout out, whatever's easiest. But Andy, you can look at the chat and see if there's anything you'd like to pick up on.
Yeah, okay, so of the things that have come up, first of all, the haloperidol story comes up first. Now, remember that haloperidol is Serenase. It's all the same company. They all are difficult to find. It's a global supply issue. It's not a local supply issue. If you've got a little bit of it floating around because your pharmacy happens to come, that's fine. Do not go for trade names. The state buys by generic name. We get what we can get, and the National Department of Health is actually very good at getting what is available. When there's a global shortage of the drug, nobody in the States can get it. It's just not made or not available, and that's where we've been with haloperidol lately. And the trouble with these drugs is that once they get beyond a sell-by date, nobody wants to make them. They're dirt cheap. There's not a lot of profit in them, and there's lots cost more and make more profit for companies. So that's why South Africa's gone with clothiapine and the others ones I mentioned in the absence of haloperidol. It may come back, we don't know, but be that as it may, those are alternatives at the moment. If you've got some parenteral haloperidol, lucky you, but once it's finished, it's probably finished. The Ringer's story is exactly that. Ringer's hasn't got enough potassium in it. Okay, so if you're trying to replace potassium, you can't make do with Ringer's. It's dangerous because it won't give you enough potassium. Okay, it's not a better resuscitation fluid, and that's what the whole point of this thing is. So this is $1 billion industry in the States, proving that your balanced crystalloid, which is what Ringer profits made for decades or more to come. At the moment, the data is getting more and more conclusive that nothing is better than saline, which is dirt cheap and available the world over. The problem is exactly this, though, that it would be nice if we had a high potassium fluid to use, in other words, a premix with potassium in it. And that's why Ringer's is tempting, but unfortunately doesn't have enough potassium. You really do need to throw the stuff in quite large concentrations. What I'm saying about 40 millimoles is what I mean. So most of the fluids, I think Maintelite has got 15 millimoles. Most of them haven't got enough, and you need quite a lot more than that. So be careful of thinking you're doing a good enough job with just Ringer's. You may need something a bit stronger. Most pharmacies will make it up if your hospital is sensitive about letting IV potassium loose in the wards, which is a reasonable thing to be concerned about. And elderly patients certainly can have a UTI causing a DKA. But that's why I was saying you must look for everything. It's not always a UTI. It can be something else. By all means, think about it and always check them. The patient with inverted T waves, sure, that's part of the evolution of a MI, and it will happen every now and then that you will see a late presenting patient who's got the fully evolved thing with all the features. I'm not sure what Tabo's on about there. Is that not worse with a hemorrhagic stroke? Well, you talk about the aspirin. If it is the aspirin story, we've put that in the EML handbook. The issue there is that, sorry, is that what you were asking?
Yes, that is what I was asking.
Yeah, so we've put that in the EML handbook. We went into it in extensive detail. It's based on a trial that is 20 years old now, of 40,000 patients, okay? And inside that trial, what happened is that by accident, they gave aspirin to folk with hemorrhagic strokes in a smallish group, a few hundred, but it was enough to be very thought-provoking, because what it essentially showed is that although you did have more bleeds in the group given aspirin who'd had a hemorrhagic stroke, overall, they were more likely as their next event to have an infarct, and that was reduced more than the bleed was. So that overall, giving every patient with a stroke some aspirin is better than not doing it. And recently, a couple of years ago, some health economists got hold of this data and said, well, what about Africa, where we haven't got a lot of CT scans? What would be the story there if you just gave out aspirin in general? And it was quite definitive that their sort of modeling showed that giving aspirin to everybody would be better off overall than not doing so, and pretending
Thanks,
that you've
Prof.
had access to a thing. The only problem, though, is obviously you don't want to give it to somebody who's clearly had a hemorrhagic stroke, and there are signs of that which are very obvious. So somebody who's got a splitting headache, somebody with a massively reduced level of consciousness, somebody who's been vomiting, those are more likely to have hemorrhagic strokes. And obviously throwing aspirin at those doesn't make a lot of sense. But in general terms, a small bleed, it's more likely that the next event will be an infarct than another bleed. So it's probably not unreasonable to do that, and particularly if you have difficulty accessing a CT scanner in time to make much difference. The data on aspirin's duration of benefit is also changing. It probably is mostly in the first 6 weeks. So long-term use of aspirin in stroke patients may not be that important, but that data is still evolving. I don't know if there's anything else. Let me just look down there. Yeah, switching when you're out of stock of oral phenytoin for quasi-status, in other words, those folk who are coming in and have acute episodes of seizures. It doesn't really matter. I mean, the problem is lamotrigine is not readily available in the sense of you can't escalate the doses high enough, quick enough. So it isn't really much of an option for acute management of epilepsy or fits. But in that situation, probably it's reasonable to use oral valproate. It gives you a relatively quick onset of action, and remember, you can't crush that. Okay, so squashing that and chucking down a nasogastric tube doesn't work because it's a slow release pill. So you have to have the valproate solution, which is obviously the pediatric preparation, and that you can bung down a nasogastric tube, but you'll have to do that 3 times a day. You can't just give it once a day, obviously. Yeah. All right. Easy way to confirm constrictive pericarditis with it. Yeah, no, it's a no. It's not easy to confirm it constriction. Constriction is a clinical diagnosis, and you can get lots of great clues, and you can certainly make a diagnosis of a heart that's in trouble because of constriction on echo. But again, what you're looking for is a fluid overloaded patient. They often are relatively comfortable, but with a very high JVP and swollen legs, perhaps sometimes more of a swollen tummy than swollen legs, and a pulsus paradoxus is obviously a very helpful thing. The blood pressure will be low. The paradoxus, as you know, is that change in systolic blood pressure as you breathe in and out. So they're breathing normally. You don't tell them to change how they breathe, and you just listen to the systolic blood pressure at the top, cough 1. And if it comes and goes, and there's a big difference in the distance between where it first comes and go and where it becomes constant, that's your paradoxus. And if that's high in a patient with a raised JVP and a small heart on a chest X-ray, you're in business. That's constriction. But if in doubt, these are not medical emergencies, you can send those on to us and we'll have a look at them. Yeah, do you suggest trying to manage DKA without a blood gas machine? Well, I mean, the short answer is I have to manage a DKA without a blood gas machine every time the cartridges run out. So we do this all the time. And, it always amazes me that we have to accept these patients and manage them for somebody else when sometimes the site that's referring has a blood gas machine. KCL is always available. It really isn't out of stock. I think that's a pharmacy issue and needs to be taken up with your pharmacy. And if they say they can't get it, we need to sort that out. You see, the DKA refusal really is about who's got the blood gas machine. Unfortunately, a company, that supply the machines all over the province is paid by Bishu. And so in the Eastern Cape, at least, the company being not paid means that nobody gets it. So there's cartridges in various stages of usage around the province. Each cartridge costs about 13,000, between 13,000 and 20,000 rands. And when it bombs, you can't use it anymore. And you'd have to put in another one. If you haven't got another one, that's where you're stuck. But yes, you can manage DKA without a blood gas machine. I'm not saying it's ideal or something we'd want, but I've done it lots of times over the years. It's not safe. And obviously, if you've got a blood gas machine or access to a place that will take a DKA that have got a blood gas machine is working, then that's ideal. Okay. Good. Anything else?
Thank you very much, Andy. It looks like, yes, there was lots of nice little interesting, all those little top tips that make such a difference. And thanks for covering such an amazing amount of, the little things in a 1 hour talk. That was really great. Thank you very much. We'll also make the recording available, and we'll put that, the link of your website, we'll also put in the resource pack that'll be going out tomorrow morning. And we will have various references for non-communicable diseases in general, and then specifically also on some of the BAMC material that Andy's been doing with Prof Parrish has been doing with the local rural hospitals. So thank you, everybody. So just for next week, we are going on Monday night. So we're moving on next week to the surgical side of life. And on Monday night, we're going to have a lecture from a rural doctor from Zetulele Hospital. Dr. Hans Hendricks is going to be covering fractures with us, a similar sort of tour through a variety of fractures with some top tips. And then on Wednesday night, I'm still confirming the exact topic, but we're going to have Prof Bishop from KZN to come and do something for us on anesthetics, which we're very excited about. So we're looking forward to that. So once again, Prof Parrish, thank you very much for giving us some of your time this evening. We really appreciate it. And all of you have a lovely evening. And we'll see you next week.
Good. Thanks, guys. Enjoy your evening.
Good night.
Cheers, then. Okay, Madeline, is there anything else you need from me, or are we finished now?
Yeah, no, that's perfect. Thank you very much. That was great. And then I'll put the recording. We do put the recording on YouTube, and I'll send you the link and all of that. And then you're welcome to obviously link it also to your website. Have a lovely evening.
Cool. Yes. Now I think we must start to make sure. Yeah. Yeah, I think we must make sure that the two websites start to talk to each other as much as possible, because they obviously have got a lot in common.
I don't even have a website. I don't have a website. We just have a YouTube channel at the moment. We don't even have a website. So we are just, the rural onboarding is just a portal. We're just creating links. And maybe BAMSI might even be a portal. So we're not somebody, we don't actually have our own sets of resources. We are linking to all these different amazing stuff out there. It's more like a roadmap for people. And we'll definitely put BAMSI on the roadmap. So it's sort of when a rural doctor is sitting and looking, okay, where do I go look for internal medicine stuff? Where do I go look for orthopedics? Where do I go find emergency medicine? Where do I look for pediatrics? That we can easily point them in the right directions. They don't end up on some obscure American
Good.
site.
So, I mean, what we're trying to do is put some non-internal medicine stuff on too. So we've got some ophthalmology talks,
lovely,
a bit of psychiatry, and you know, I think a lot of these things start to link up and become very worthwhile. I mean, one of the key things we're trying to look at is to make sure that you don't have to look too far. You know, there's just so much out there now that you can scrounge around and get a dozen different messages.
Yeah,
so we're probably on the same page.
Yes. So it's also, we don't particularly want to duplicate. But yeah, so we're trying to keep it relatively simple and just give pointers in directions, sort of for one easy place. So when a doctor starts at a rural hospital, but we will certainly look if there's, how those two cooperate, so to speak. So we don't just end up having vast amounts of duplication. But yeah,
what we've set up, which we aren't very good at, is quality control on the talks. Okay,
yes,
so they're
Simon was
supposed to
talking
be
about that.
on the BAMSI site. They're supposed to be signed off on, and that there aren't any mistakes, and that they're saying things that everybody thinks is right. It's actually quite difficult to do that.
Yes.
But it's certainly something we're looking at this year. We've got a new fellow, so from RGH. So we've got some extra manpower.
Yeah, with rural onboarding, that's been almost, it's the practicality of that is slightly beyond us. So at the moment, we are just posting the webinars, and we're inviting the kind of people that are on the top of their field. So you would assume that, but it's a specific person teaching a specific set. And of course, there will always be possibilities to disagree on fine points, on details. But because of the quality of the speakers, I've not been too concerned. And then of course, I do a vague listening in, but of course, me vaguely listening on emergency medicine is probably a bit of a waste of time. But certainly on some of the medicine topics and things, one can get an idea that, no, this is probably all very much going to be useful, and you're not going to end up killing patients, which is always the worry. So we've not yet got a formal process for that. What we are looking at, obviously, is once you put stuff on YouTube, that they have an expiry date, so that you don't have things that just stay forever without rechecking.
Okay. Yeah, that's clever.
Yeah, so that we do have a process for that, because the problem is
we
with
must
HIV,
do that too. Yeah, no, that's important.
Things become out of date or information change, and now we're using dolutegravir. Yeah, we're now going to, all of these things are changing all the time. So
that's clever.
Yeah, so that's about the only thing. But the quality assurance, it's interesting. Yeah, it would be lovely to chat with you, actually, because you guys have had a really good experience in terms of doing lots of these webinars, and then looking at what you post and who checks them and how you check them and all of that. But luckily we've got Simon now as well, so I have the background story.
Yes, you've got it. Absolutely, okay,
great.
And Holly's now officially part of the IGH initiative too. So some of her hours are actually
that's very exciting.
For BAMSI now.
Okay, good. We really, I mean, once the rural onboarding is over, my life will hopefully return to some sort of normal. And the HIV diploma is being written in 2 weeks. So I've managed to put it all in the same month, which is a bit nuts. But so we're looking, then I'll have a little bit more time. And it'll be nice to sit down and look properly from the mentoring point of view. We've also got the Rural Health Conferences coming up in August, and will be in Oudtshoorn, which is not that far. Well, it's not as far as Limpopo. So it'll be nice to look at, we want to do some clinical workshops and things there as well. And especially on the mentoring side.
Okay, that'll be fun.
Yeah. But have a lovely evening.
Cool.
Thank you very much. And I will see you around CMH.
And you too. Cheers then.
Thanks. Good night.
Yes, there we go. Okay, cheers then. Bye.